The first thing they need to do is they need to try and seek some kind of professional help quite quickly, because the longer it's untreated, the more damage they do to themselves and to the bond between them and the baby. With perinatal OCD, there's no actual risk of the people acting on the intrusive images. And I want to be very clear on that for anyone who is experiencing those things. It's extremely unlikely you'd ever act on them. They're ego dystonic. They're not something you want. It's just that you can't stop thinking about them.
Welcome to OCD Whisperer Show. Today with me, I have a guest from Dublin, Ireland, guys, Conal Harpur. He has worked in multiple settings, including a research department in Ireland's top university, Trinity College of Dublin, as well as a locked psychiatric unit and psychology department. He's currently completing his doctorate in psychotherapy, where his special interest area is in anxiety disorders and OCD in the perinatal period. He manages the CBT department in a busy maternity hospital in Dublin, Ireland, and also has a private practice where he treats moderate to severe mental health problems. Welcome to the show, Carl.
Thank you very much for having me.
So you and I actually connected on Instagram briefly, and we talked a little bit about OCD. And even just now before recording, we talked about the international component of providers. And you said your specialty and what you're focusing in on is perinatal OCD. So can you tell us, like, what is that exactly? What is perinatal OCD?
Yeah. So I suppose for people who are unfamiliar, OCD is obsessive compulsive disorder, and the perinatal period is a period in a woman's life between pregnancy and postnatal. And so it's the period of pregnancy and for 1 year postnatally. And perinatal OCD is people who are experiencing obsessive compulsive disorder within that period during pregnancy and 1 year postnatal.
So with perinatal OCD, what kind of symptoms do you think somebody might have, just so they can, as they're listening to you, start to see like, hey, is this something that I'm having?
Yeah, I think that there a lot of the kind of classic OCD symptoms, so cleaning, checking, etc., can become much worse in perinatal OCD. But what people will often find is that there is a increase in the responsibility threshold, obviously, as a new mom or worried about carrying the baby. And what tends to happen is that kind of fuels more intrusive images, and the intrusive images tend to be around infant-related harm thoughts, or IHTs, or that something bad will happen to the baby, not necessarily as a fault of the mom. And that's what kind of separates maybe perinatal OCD from kind of standard OCD. It tends to be related to the baby and the welfare of the baby.
So you're saying that if somebody has that their OCD will basically attach to anything and everything around, it sounds like, the safety of the baby.
Exactly, yeah. So in classic OCD, the kind of CBT formulation of, or understanding of it is that the intrusive images have a weight to them which makes them morally repugnant. They're what are called ego dystonic, so they're morally shameful for people, and that's why people find the intrusive thoughts so distressing. So if you think about this, a very kind of classic example is that a straight man will have intrusive images of having sex with other men, or a person will have I'm just trying to think. Someone who's extremely safety conscious will have intrusive images about their house burning down as a result of their fault, and that's where the shame kicks in. And so they're the worst things that could happen based on that person's kind of moral stance or where they see themselves, their ego. In perinatal OCD, what tends to happen is that women try to pride themselves on being the best mom or being a very good, loving mom. And what tends to happen is that the worst thing that could happen is obviously something terrible happening to the baby at their hands. So the intrusive images, it can be them dropping the baby, them hurting the baby intentionally or unintentionally. And so that's the link there.
Got it. And so then it sounds like if they're having that, obviously, then they're going to feel this intense urge and need to repetitively, compulsively continue checking to make sure that they didn't do that, or checking that they didn't drop the baby, or that they didn't do anything wrong. They might, I would imagine, probably mentally also ruminate on things or review things.
Yeah, so it can be they can have obsessive rumination. What you tend to find in OCD is that people tend not to avoid, they tend to engage in a behavior. So the compulsion is a way of avoiding the anxiety, but it's not a behavioral avoidance, if that makes sense. It's more of an emotional avoidance. With perinatal OCD, what you'll tend to find is that if I have an intrusive image about me hurting my baby or walking down the stairs and dropping my baby on the stairs, is a very common one. I might be more inclined to not engage with my baby for fear that I may act on it. And so for like a lot of your listeners that may or may not know, one of the kind of core cognitive distortions that exists in OCD is that a thought about something happening is the same as it actually happening. And so people tend to worry an awful lot that if I think it, it'll happen. So if I think about dropping my baby, it's guaranteed to happen. Therefore, that creates the anxiety, the shame, the guilt. So they tend to withdraw from the baby, and that obviously impacts on the bond, the attachment, and it can have interpersonal problems in the relationship if it's not a single mother.
That's amazing. And then you also mentioned the word emotional avoidance. Can you talk a little bit about that?
Yeah, so for a lot of people, I suppose this in OCD, what they are trying to do is that when they have an intrusive image, so a kind of classic example is people who check stoves or fires at nighttime to make sure they're gone out or turned off. What they might have is an intrusive image of their house going on fire and them or their family being burnt to death. That causes an intense level of anxiety, and they feel that by not checking to make sure the stove is off, they are failing in their duty to protect their family. This induces a sense of shame or guilt, which is the ego dystonic piece, not who they are. And so in order to avoid those feelings or guilt or shame, they will carry out the compulsion. So they will check the stove or check the locks to make sure everything's okay, so that they can kind of go, phew, I feel like I've avoided the shame. I feel like I've avoided the guilt. I've avoided the anxiety through preempting and preventing the catastrophe of my house going on fire. That can be a form of emotional avoidance or just not engaging with.
Got it. And so if someone actually has this kind of presentation in OCD, and if anybody listening, what also Conal just said, which I want to highlight, is that we're treating the OCD, the disorder, right? So understanding broadly how OCD operates, that there's this process where you have intrusions, you feel intense emotional distress, and then you feel driven to engage in repetitive behaviors, which can be mental or physical, which are compulsions, and recognizing that whether it's attaching to a perinatal topic or harm or morality or relationships or contamination or whatever it is, being able to step back and globally more understand how the disorder works. And so, with that, again, if somebody is having this, I can imagine, of course, it's really hard, right? Because all OCD is difficult, but I think some topics for some folks can make it even more sensitive. And so, what can somebody do, or how can somebody work with this kind of presentation?
The first thing they need to do is they need to try and seek some kind of professional help quite quickly, because the longer it's untreated, the more damage they do to themselves and to the bond between them and the baby. With perinatal OCD, there's no actual risk of the people acting on the intrusive images. And I want to be very clear on that for anyone who is experiencing those things. It's extremely unlikely you'd ever act on them. They're ego dystonic. They're not something you want. It's just that you can't stop thinking about them. So the first thing is, what a lot of people tend to do is that when they have intrusive images or intrusive thoughts, they try and block the thoughts out. And what happens is, in order to block a thought out, you need to think about what the thought is. So it's counterproductive. You need to invite it in order to block it out. And what happens is that kind of accelerates the thought process, and people feel like they are losing control or going mad. And then they think, oh my goodness, if my anxiety is this high and I can just lose control, maybe I will act on the thoughts that are distressing me. And so people get very confused and convoluted in their head around that. And that's what really causes the distress, is the unpredictability or perceived unpredictability of it. And so it's about trying to find a therapist who really, I suppose, understands OCD, understands that transition into motherhood or fatherhood, depending on who's suffering, and can hopefully help you make sense of that experience. That'd be my advice. There's also a international algorithm for the treatment of OCD. I think it's Hutner et al. 2021, that looks at the gold standard treatments for OCD. There's an international algorithm for perinatal OCD as well, and it looks CBT or cognitive behavioral therapy as first choice, and then combining that with SSRIs, and then failing that, looking at like a clomipramine or something else as a medication of choice that can be quite helpful. But again, that's up to people to speak to their doctors around that.
Got it. Yeah. And when we're talking about CBT, we're talking about like exposure response prevention kind of stuff, right? Acceptance commitment therapy. And I don't know if anybody knows or has heard of also inference-based CBT. I know one of the things you and I've talked about, and this is interesting because you've brought this up. So I thought this could be an interesting point of discussion for folks to hear. We usually talk about OCD through the lens of evidence-based practices like the ones we just mentioned, right? ERP, ACT, ICBT. But you mentioned something like looking at it through psychoanalytic psychotherapy. So can you tell us what that actually means?
I most certainly try. So I suppose when we think about psychoanalytic psychotherapy, really what we're talking about, for people who are unfamiliar, is Sigmund Freud and the development of psychoanalysis in the early kind of 1900s. And Freud wrote a very famous paper about obsessional neurosis in his case called The Rat Man. And basically, Freud theory emerged from that case. I think 1909 or 1919, I can't remember exactly, but the idea that we have this kind of tripartite model of who we are. So in psychoanalysis, the idea that we have the id, the ego, and the superego. And the ego is a moderating force between the id, which is impulsive or aggressive urges, and the superego is a kind of hyper moralistic and judgmental self. And the ego regulates the two. And so Fenichel in 1945 expanded on Freud's work to look at maybe how the superego, the hypermoralistic part, expresses severe judgment on the id's repressed sexual or aggressive urges. And so it's about the kind of urges they may have towards their parents or towards the world in general, and that the superego is judging them. So they're caught between this kind of moral battle between impulse versus importance of containing it. And they don't have this, they have an ambivalent sense of self, so they can't regulate it. And so you see that play out in, like, we all have intrusive images in the general public. We all have images that come into our head or intrusive thoughts, and we don't pay them much either. Like, oh, I thought that's okay because I know who I am and I know I'm a good person. Whereas with OCD, because of that moral component, they're caught between, well, am I a good person? Am I a bad person? And when they have then intrusive thoughts, that kind of fuels the fire of maybe I am a bad person because that's why I have these thoughts. And it's that undefined sense of self. And so in more psychoanalytic therapy, it's about using that countertransference and looking at kind of attachment dynamics in their upbringing as a child that would have developed to their sense of self.
It's very interesting to hear all this because I can already tell you 100% anybody listening right now who just heard all of that, their head is probably spinning because typically when we talk about OCD work, we really talk about cognitive behavioral approaches. We really get away and don't talk about psychoanalytic approaches or Freud or any of that stuff at all because through over the last 60 years that ERP has been around at least, and ACT, I think, has been around for, since like the 70s. And like I said, now ICBT has been around also for like 25 years. All of these CBT approaches really over time have shown our understanding that CD, there's a brain component that's happening that's essentially a person is not able to categorize or process correctly when they're getting that error threat message. When you're bringing in the psychoanalytic component just now, right? This is the stuff that just in the field, at least here in the States, most people would say, oh my gosh, no, we're not doing that. So this is an interesting conversation, right? Because what I'm also really hearing you say is it's interesting because there's an element of this that connects to not just addressing kind of the straightforward OCD parts, but also stepping back a bit further and looking more globally. How did you develop your sense of self? Like, what is your vulnerability? What are your insecurities, if you will, that at least that's how I'm hearing it, right? That OCD will latch onto or OCD will use against you to badger yourself, really, and to say, oh, see, you could be this horrible, terrible person. And maybe you really do have these terrible intentions and desires. And you now have to sit and just spend this exorbitant amount of time trying to figure this out, hence the compulsion to try to prevent that from being true.
So one way to look at this is that like an individual may develop perfectionistic traits as a defense mechanism in psychoanalytic terms against the kind of reoccurring unacceptable impulses or thoughts they may have growing up. Okay, so let's say that I grow up in a house that is unstable, where my mother or father is quite aggressive, and so I don't feel very safe. I may have certain kind of negative thoughts or impulses towards my parents because I'm quite scared of them, but at the same time, I depend on them. And that's quite a frightening place for a child to be. And so sometimes they may have intrusive images or intrusive thoughts, and they may try and offset that by developing certain characteristics or traits as defense mechanisms. So maybe like tapping my head or doing things perfectly to avoid being in trouble or whatever that might be, that feeds into, in terms of what's called object relations theory, or I suppose for people who are unaware, there's kind of CBT is kind of umbrella term that incorporates multiple different therapies. And one of the derivative therapies is schema therapy that was developed by Jeff Young, and kind of Young and Bricker in 1993 did an interesting paper on that. And what they're talking about is the development of cognitive affective schemas, and these are repeated interactions that shape our worldview and the way that we behave as a result. And so a child that is kind of maybe criticized repeatedly they will have to deal with a lot of guilt and shame. So they may develop perfectionistic tendencies to offset or to reduce the emotional distress they feel. And that becomes their way of coping or working through the world. And that then may be exhibited in times of intense responsibility when it comes to, say, looking after their family's safety. That perfectionism may go through the roof and become an unhelpful part of their personality, and maybe checking locks frequently, and that might occupy a lot of their time. And that can be a way of offsetting or not dealing with childhood traumas that are otherwise dealt with. And I suppose the reason that I took the view of the kind of psychoanalytic object relation theory and schema therapy view of it is because I'm yet to meet a client with OCD who grew up in optimal childhood environment. And there's enough research that we know that CBT is not necessarily getting the job done. And there's a lot of people who finish what are deemed successful courses of CBT, but they're left with residual symptoms. And that happens in around 35% of cases, according to some of the randomized controlled trials. And so I'm trying to maybe separate out treating the disorder and treating the person, and trying to not miss them in the treatment of the disorder, if that makes sense.
Totally. Like I said, I think this is a very interesting conversation and episode. And I know anybody listening, there's going to be a whole slew of questions and triggers that are going to come up because, again, in the States and even in general, I'll say this year's International OCD Foundation, when I attended that conference, that there was interesting conversations around starting to look at combining things like exposure response prevention work with dialectical behavioral therapy training for some of that emotional regulation and things like acceptance commitment therapy processes all together, and really looking at expanding our knowledge base of, because the reality is clinically, for example, in my treatment with folks, I have seen plenty of people who don't actually meet the criteria for PTSD or trauma. They haven't really quite had something like that, but they still exhibit pretty intense OCD symptoms.
Mhm.
And then I've seen folks who have had, kind of small T trauma and then big T trauma where they meet the criteria for full on diagnosis of PTSD, but they've had more, yeah, just different traumas that I guess if we think about it as humans in general, we all go through different traumatic experiences throughout our lifetime. And that with their OCD sometimes would really make the OCD flare up. And other times the OCD did not necessarily become as intense. But one element that's been true throughout everybody, and again, this is something clinically that I've seen, this is not research paper here, but it's more the degree of stress that people go through. That the moment you have intense stressors in your life and the degree of stress increases, that definitely seems to have a correlation with kind of increases in your symptoms.
That was actually found in a couple of different studies on obsessive compulsive personality disorder, where they realized that the rates of success are heavily correlated with baseline levels of anxiety. And so that's why more applied relaxation techniques are used towards those kind of personality disorders rather than the kind of cognitive behavioral therapy approaches. It's more about the emotional regulation use, as you said very correctly, bringing in supplementary therapeutic. And so Marshall Linehan and Linda DeMeff's dialectic behavioral therapies are very good for those kind of presentations for that reason.
Exactly. And like you just said, right, OCPD, a personality disorder, is very different than
Mm.
OCD disorder, because with a personality disorder, that's where somebody's very focused on a little bit rigidly on rules, regulations, how people should behave, and things like that, versus OCD. It's really marked with that intrusive process, intrusive images, feelings, thoughts. All of it goes against who you are and what you want, versus an OCPD, a personality disorder. It's actually an alignment. People will say, no, this is how things should be. This is the right way. So there is that distinction. But I think really more globally, again, what I'm really hearing here is understanding and interesting why making this correlation as we're talking right now, because an inference-based CBT, which is a cognitive model, one of the modules we cover is understanding the vulnerable self theme. And we look at what that vulnerable self theme, that feared OCD self theme is, and we understand that part of how that develops, it's based on some of these, sometimes our earlier experiences as well, that creates these kind of insecurities. And then the brain will start to latch on, because that's what OCD brains do. They'll start to hyperfocus and latch on to certain pieces. And then suddenly you're very hyper-focused on just that aspect of the self and forget that, wait a minute, I'm a whole being and there's so many other things I do but I'm suddenly not even taking that into consideration.
Yeah, I think that it's important for people, especially who are treating OCD, to remember that OCPD or obsessive compulsive personality disorder and obsessive compulsive disorder are very different disorders, but that there is a huge overlap in the presentation, and that people that present with obsessive compulsive personality disorder, there was a study in 2013, I think Freiburg did a study that found there was a 52% comorbidity between the two. So there's a huge crossover, and I think a lot of therapists can get quite stuck if they apply purist CBT to those people, and maybe miss some of the other factors, as you're saying there about the trauma, if they don't have kind of acceptance commitment therapy or DBT or other schools or modalities to draw on to target particular difficulties that people experience. That's in my clinical experience. I found that anyway. It can be challenging. And I think that what you're saying around kind of children and upbringing is that one thing that I've learned, it's something that I've experienced a lot clinically, is that I say mums because I work with the female population. We don't treat them fathers. It's they are trying to protect their children from their own childhood experiences. There is this kind of psychoanalytic component to it, of that inner child piece, that they're trying to make sure that their child doesn't have their life. And the only way they can do that is by giving the child the best possible life. So that responsibility threshold, perfectionism, it's all at peak. And obviously, whenever there's a massive rise in responsibility, there's going to be a massive rise in intrusive images, and that's going to fuel the OCD. And so it's about kind of targeting the OCD symptoms to reduce distress, but also trying to understand what has happened in childhood that has led you to developing this as a way of coping. And how do we unpack that? And you're right, it is an unpopular thing to talk about psychoanalysis, especially in CBT, in the same sentence. I'm sure some of my colleagues might take the holy water and garlic out when I come into the room, but I think it's really important that people are aware that just because psychoanalysis and hasn't been shown to work, it's interesting that schema therapy, which a lot of the foundations of schema therapy is built on a lot of psychoanalysis and object relations theory, like schema therapy is showing validity for various treatments, and it should be integrated. So I'm trying to work towards a more blended, holistic model of treating OCD for those people who CBT specific treatment doesn't necessarily work.
Well, yeah, it's like you said, right? We know that there's at least 30% of the population that does not respond to standard CBT ERP treatment. So it's a big number, right? And it's like, okay, well, what do we do and how else can we help folks? And I have to say, over time, even for myself, like, first of all, yes, the two words together in a sentence in the community for therapists saying psychotherapy and CBT, it's like, what? There's an immediate reaction. But my goal with the podcast is to just continue to have different conversations of all sorts. I think that's valuable to have us to just reflect on things and not deny and not stop using things that we know work, but continue to expand upon what else are we seeing, though, especially clinically in the room, or what are we seeing through the data? Like what is going on with that 30%? Or, okay, you've successfully managed the kind of OCD symptoms, but then what else is there? And then knowing how do you address some of that stuff. And that may be with an OCD specialist, and that may not, right? It may be that the OCD specialist needs to know to say, now might be time to refer you out to this next step. But I definitely hear that, being able to understand sometimes earlier childhood pieces may be relevant and sometimes they may not. But that is a skill that you have to develop to understand when and where does that seem to be actually important as OCD is manifesting, right? And what the function of that behavior is. What is it really about? What is it trying to do? Where is that coming from? And sometimes, again, that is important. And sometimes it really isn't per se from anything deeper. It's just because it's OCD and OCD is creating some story about it.
I think as well, it's about the client's level of readiness or willingness to accept that their childhood experiences may have had an impact on their development. And I think that there's enough literature that exists in the developmental trauma space that a lot of clients aren't ready to go there. And that's okay. And I think that's where it is about treating the disorder. Like if you work in a kind of public health system where you're extremely time limited, it's about symptom reduction and it's about stress management. And that's the kind of the core emphasis of the public practice, is it's trying to reduce that unless you have the flexibility to do that. And I think that in private practice, people have the luxury of being able to afford the finance and the time to pursue those potentially deeper questions about like who am I actually and what was it like and what is my attachment style and how do my parents' relationships impact on me and my sense of self and my relationships and what was it like actually when my father or mother was drunk and I was a 4 year old. I never actually thought about it, but now that I do think about it, what would it be like for any 4 year old to be exposed to that? And they can ask those deeper questions about who they are on a more core level. And I think it's very hard on people to, I see kind of CBT slash psychotherapy is you've got two options. One is treat the disorder, and the other is a potentially transformative journey. And I think that you need to cut your cloth to measure. Because some people are very keen on the transformative piece, but might not be ready to go there, and that's okay because trauma is a lot. And if you're in a position like a lot of my clients would be who've gotten a perinatal OCD, and you see this in treating teenagers as well, where it's actually really hard to go into the childhood trauma because they depend on their parents for so much support. And it puts them in a very difficult position because, oh, I need my mom or my dad to pick up my kids from school and do a bit of babysitting. But at the same time, I need to deal with the fact that they were actually maybe physically abusive to me growing up. And now is maybe not the best time in my life to do that. You know what I mean? So that creates a huge challenge for people. So people need to be in the right space for that. And people have their whole lives. So it's about taking your time, but also not betraying your future self and letting yourself down by not asking the bigger questions and taking on the bigger issues.
Yeah, Conal, thank you so much. This has been definitely a very interesting conversation. Like I said, anybody listening, I'm sure a lot of things have been stirred up. Sit on it, process it, maybe re-listen again. So if anybody is listening to this and they would like to find you, how can they find you?
Yeah, www.cbtsolutions.ie is my website. And my Instagram handle is cognitive_Conal. So cognitive_CONAL.
Awesome. Thank you so much for being on the show.
Thanks for having me. Really enjoyed it.